Well, thanks so much for watching Making Healthcare Work for You, different perspectives and empowering solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta, and today we are pleased to welcome Dr. Elias Zerhouni, who is the former director of the NIH under George W. Bush, presidential envoy under President Barack Obama, and consultant to the White House medical team of President Ronald Reagan. He's also the author of the recently released book, Disease Knows No Politics. Thanks so much for being here.
Thank you. Thank you for having me.
You have so many amazing things that you've done. And when we were talking to you in the pre-interview, I think what struck me the most is that you kept coming back to the journey that you've had through medicine and through your career. So why don't you just tell us some about that journey, what really stands out to you over the years?
That's exactly right, Stephanie. I wanted to take the reader through my journey, but not as a work of introspection. Oh, here's my autobiography. No. I wanted to take them from where I came from. I'm an immigrant. I was born in Algeria. I came here at age 24. I went to Johns Hopkins. And then all the events that went through from 1975 to 2025 in my sort of radar, if you will, and share that with the readers and touch the points of bifurcation when things occurred that really indicated a change in the context of biomedical research and science and the context of healthcare. So it's a journey. It's a journey that is like come with me in my car, going, back in time, and I'll show you what I went through, but I'll show you a mirror of what the society was in 1975 when I came here to what it is today. That's really the purpose and the structure of the book and my intent here.
Wow, Dr. Zerhouni, just you're describing that just sounds like what an incredible ride we're in for. Back to the future, as they say. So I would just love to hear maybe a few of the interesting mileposts that you crossed, or some of the things that really stood out to you on the course of that journey that you think our audience would appreciate learning about.
Well, first of all, let me contrast the beginning and the end, okay? So when I came to the United States, I was, awed by the American healthcare system. I thought it was the best in the world with the best discoveries. And if you remember 1975, when surgery exploded, operations of incredible complexity were done, transplants and so on. At the same time, imaging was coming up. And so I was excited and I said, this is the best of the best, both research and healthcare. Fast forward, I no longer think our healthcare system is the best in the world. I still think that our biomedical research enterprise is the best in the world. So you've seen a bifurcation over 50 years between what creates progress in medicine and what medicine itself has become. When I started in my NIH role, when I met President Bush, who had a few people selected for his consideration, he told me, he said, listen, I want you to know, I'm going to make sure that the NIH budget is doubled. You understand? And if anybody tells you otherwise, you call me. And he was very gregarious. It was very easy to get along with. And then he said, and I want to make a difference in HIV/AIDS around the world. Fast forward, this was 2002, 2025. Oh no, we want to cut the budget of NIH in half, and we want to stop whatever we do in HIV/AIDS. And on top of that, COVID-19 vaccines and all the things you hear today. So you can see that we've gone through a tumultuous time. And I wanted to share that because I think it's a unique journey, because I went from academia to government to industry to philanthropy. And I thought it was worth sharing.
You said a number of things in there that were really interesting. And so you said you saw a bifurcation of the biomedical research and then the healthcare system, that we're still the best for biomedical research. We're not the best healthcare system in the world. Do you think that there's a perception maybe that people think, okay, we've done it, we're there, we have enough? Or do you think that there's just like a fundamental shift in the way that people want to approach healthcare? Not politically, just in general.
Right. I think in my view, there is a need to fundamentally shift how we think about healthcare, because it's not working. I mean, if you talk to people, I talk to patients, I talk to people who call me and say, could you help me access healthcare? Oh, this is too expensive. Is there any way I can avoid that. The fear of people going to a hospital, even a hospital as generous and nonprofit as Johns Hopkins, is receiving bills they can't pay. 50% of the people are facing medical bills. So you can't say that we have a great healthcare system anymore. If you look at our health statistics, they're not that great compared to other countries, and we pay twice as much. I mean, that's amazing. So the question is, how did we get there? And I'm going to tell you something. You know, there's always a finger pointing that goes on, but I've learned the fact that a system is designed to give you what you observe, right? And then when you go into it, you realize that a number of people made very rational decisions all along. The problem is, and I'm a scientist, a mathematician, physicist as well, is that in mathematics, we say a series of rational decisions is not always a rational outcome. So the sum of rational decisions is not always rational. In fact, that's the symptom. We have made a ton of decisions by a ton of people thinking that they were doing well for themselves, well for the system. And at the end of the day, you end up with an irrational system where the tensions and the contradictions are enormous. So you have providers who want to provide more, you have payers who want to provide less, you have denials and you have pre-authorization, which have appeared over time. And it's changed from a provider-controlled system to a payer-controlled system. But the big problem we have, as opposed to other countries, is we don't have an integrated approach that is close to the people. In other words, in my book, I explained that, you know, even Canada, which is supposedly a government-controlled system, is not. It's really regionalized. And the same thing in Germany, it's regionalized. The same thing in France, it's regionalized. And it's really near the people. So it's not directed from a central Washington with a couple of experts there making all the decisions in Congress, where Congress is lobbied all the time by what I call intermediaries that don't really add value, but they extract value. So these things really are evolutions between what I thought was the best system to what I don't think is the best system anymore. And you could see it in my book. I mean, I recount the story of how I invented a method of diagnosing benign from malignant tumors in the lung. And the reason I did that is because a lot of people were undergoing surgery at the time, no matter what the outcome was. And I realized that half of them were unnecessary surgeries because it was not cancer, it was benign. And so I said, well, we should find something. And my mentor, Dr. Stan Siegelman, said, calcium is different in the benign tumor and the lung tumors. There's much more calcium in the benign lung nodule than a malignant one. So I came up with a way of measuring that with a CAT scan. And guess what? I wanted to sell it to the main companies, General Electric and Siemens, the main manufacturers of CT scanners at the time. You know what they told me? Thank you, Dr. Zerhouni, but we do not want your invention. And I said, why? I mean, it's going to save surgeries, and surgery is risky, and there are people dying from it. And they said, no, because we're going to upset our main customers. And I said, how do you mean that? And I was naive. I was 29 years old. I mean, and you know what they said? They said, our main customers are surgeons. They're not going to like the fact that your test is going to prevent them from doing their job. I mean, I was like, okay. And sure enough, it was not taken up. So a friend of mine, Bruce Holbrook, he's an accountant. He said, look, Elias, you're not in Algeria anymore. You're in the US. You can do your own company. I said, well, how do I do that? And he said, well, if you believe in your invention, do it. So we did it. And guess what? We almost went bankrupt because indeed the market forces were against the innovation. They didn't want that innovation because it took money away from some people. And so I learned the hard way that you need to understand the underlying, vested interest that you're dealing with in innovation. You can't just say, oh, I have the best thing since sliced bread, and now people don't want it. But here's what happened, which is important to the story. Insurance companies starting to notice, and I did a study with multiple universities, and we proved that if we use this method, you could save almost a third of all surgeries, right? Well, in 1985, 86, 5 years after I came up with this invention, the insurance company says, from now on, you can't perform a thoracotomy, which is a surgery, without using Zerhouni's test. That was the first time in my life where I saw the power of payers and where the power shifted from providers to payers. So I'm just giving you an example of a transition that you were asking about. What happened over time that led us from best to not so best.
Wow, it's sort of like a textbook example that you just laid out. I mean, it's so much learning there just over the course of what the time, the factors, the trends,
Yeah.
the players. I mean, it's so intriguing. I think if you haven't made a case study out of this, that could be an incredible case study. You know, the one question that comes to me then, Dr. Zerhouni, from that is, it sounds like the individual parameters are sort of being optimized in their own silos. That's sort of what Stephanie was also just indicating, that ultimately the players are trying to innovate as much as they can, but then the payers are just motivated to cut back on what they're paying, and the providers want to do as much procedures as they can. The patients want the highest quality care, and it's all happening in separate pieces. And is that why the care isn't really being delivered according to the way that it should be? You know, I guess maybe that's the hypothesis you can test for us. And then the second part of that would be, how do we do it any differently? Is there any prospect for us to actually, given how complex all the politics and the stakeholders are, that we could actually organize ourselves to deliver a better outcome?
I think your comments are right on. I mean, you're posing the right question, right? I mean, if you have a system that rationally was designed to have contradictions inside of it, what can you do? I mean, you cannot band-aid this thing. It's become a situation where you have to really think of transformative approaches, right? So a lot of people rely on basically CMS and the government and the big monopolies of insurers now. I mean, we don't have that fragmentation of insurers. We have a fragmentation of services, but not of insurers. So there's a monopoly. And you have also big healthcare systems that have become monopolies around the country. So you have this huge force, right? The thing is, the main customer is not at the table. The patients are not at the table, right? And so people are making decisions for them on a grand scale. No, you don't have that. No, prevention is not good. No, you shouldn't have this. And then they add a few things like, yeah, we agree with mammography. So it's piecemeal. It's not really focused on improving the health. It's a sick system, not a health system, right? So then when you say that, you say, well, how come the patients are not at the table? Because I'm going to make you laugh here. There's an old saying that says, if you're not at the table, you probably are on the menu. You know, and that's what a lot of patients feel like. They're on the menu, you know. So how do you fix it? First of all, remember the title of my book, right? Disease knows no politics. We have too much politics in healthcare, and politics is controlling in the Congress with centralized regulations that are made by special interests that lobby Congress and basically distort the system permanently. That's why when you have a healthcare bill, it's never bipartisan. It's always partisan. And I recount in my book how I was surprised when I was the NIH director that President Bush wanted to have drug coverage for seniors, because at that time seniors were essentially choosing between food and drugs, And I thought, well, that's a slam dunk. Who's going to be against that? Well, you should have seen the partisan battle about that, and it passed by one vote. You fast forward and you say Obamacare, what did Obama want to do? He wanted to give insurance to 30, 40 million people who didn't have it. Well, that should be a slam dunk, right? No, it almost didn't happen. It passed by one vote, and then it was fought over the next 8 years. So it tells you the fragmentation, the fracture between the patients, the people, and the one-size-fits-all approach to governance of healthcare is the problem. So how do you fix that? Number one, you should depoliticize healthcare, right? You should find a way to do it. then you should disintermediate healthcare, because my calculations show that about 40% of the spend is spent on intermediaries that do not provide significant medical value, really. Right? The third one is regionalization. Why do I say that? You know why I say that? Because I went around the country. Let me tell you something. The epidemiology and the healthcare needs of patients in Mississippi and Alabama is completely different than that of patients in Minnesota or in California or in Maryland. You know, the makeup is different. So who thinks that they can have a one-size-fits-all approach for 350 million people decided by a few powerful individuals in the center of Washington? Doesn't that sound like Soviet Union style, right? Central control. And so that issue of regionalizing healthcare and not revolutionizing healthcare, but follow a devolution, give healthcare back to where it's practiced, to regions that understand their healthcare needs, don't have the shackles that I experienced, you know, when I was at Hopkins. I mean, yeah, you couldn't really change procedures. If you want to know a specific example, I was developing CT scanners that were super fast. So we developed a technique where you could scan the entire body in 45 seconds, right? And that was our research. And I went to the hospital. I said, you know, look, why are we doing this cut up healthcare? CT scan of the head, CT scan of the neck, CT scan of the abdomen. You know how it is. You're a doctor, so you appreciate what I'm saying. Well, you know what happened? Because it didn't have the ICD-9 code and 10 code and all of the codes you have to show, and then the requirements for each test being different and so on. The general counsel said, Elias, you're going to go to jail. I said, what do you mean? It's fraud and abuse. That's Medicare fraud and abuse, what you're proposing. I said, but you haven't heard me. He said, no, I heard you. What you want to do is to bring the patient, give them the total scan for the price of one, right? Store the images. And when the doctor has a question, you can come back and look at the images. It's like you having something on your Google Drive, you know? That was a no. You couldn't do it. I can show you examples after examples of things that would be nice to try, but you can't do them because it's centralized. And I think, you know, regionalizing healthcare would be a solution that can really work, because other countries do that. You know, look at the Federal Reserve. It's not the central thing. It's 10, 12 economic regions. And that's the example I give to say you need to adapt to the local conditions. And more importantly, you need to have the patients at the table, because they will participate politically at the choices that need to be made instead of choices that are made for them.
That's really interesting. And it actually reminds me of an interview that we did recently with Wade Mitzel of U of L. Yeah. Is that correct, Apoorv? U of L.
Yes.
He was talking about his approach, and he also had a personal story with his, and he's leading that health system. And he said, he talked about how much they have to focus on cancer because that's such a big issue for them. And he, you know, other places it might not be, but it is so important to make sure that you're addressing the needs of the people in that population that could be affected by anything from weather, pollution to, you know, food, all those things that make a difference in the areas that they are. So with that, though, we are a huge country. We have a lot of things that we have to manage, and there has to be some sort of way to start with this. And in my head, as someone who does not work in medicine, it seems like we have to start this from a values place. We have to decide as a country what are the non-negotiables and start from there, from that ethical thing. We care that these things matter. And then the way that that manifests, like a corporate culture might within a company, it might be different at this branch versus that branch versus that branch, but we can all agree that these are the tenets that matter to us. It's preventive care for which, you know, those things. So am I off base on that? Is that where we start?
You're completely right. I think you need a basic understanding of what needs to be provided to every citizen. That's how France works, Germany works, and so on. And I've been working in France for a few years. I can tell you it works. I mean, people complain all the time because you don't have all you want, but you have to have a basic understanding That's number one. Number two, you have to have choice. I mean, if you want extra insurance and private insurance on top of your national thing, but the administration of that should not be centralized. It should be regionalized. Why? Because I don't believe you can manage the healthcare of 350 million people from one place. You cannot. And not only from one place, but we have three insurers in this country. You know, United Healthcare has 80 million people, it's more than Germany. You know, Germany does not manage its whole population from one government. It does it in what they call the lenders, which are sort of units of the country. The same thing is true here. I mean, my experience tells me that you can manage a population of 20 to 30 million very well because you have insurance risk, it's diverse enough. If you go beyond that, it becomes problematic. So clearly you need to have several small states that come together, so regional authorities for healthcare, and also some states that will be big enough for doing it for themselves. But I think a devolution, give healthcare back to the people. Enough of this sort of geniuses who fight all the time, can't provide solutions, and basically increase the deficit in this country because healthcare is the major cause of growing deficits, which force you to de-invest in research, de-invest in education, de-invest in a lot of things that are not as sensitive as healthcare. It's not right to spend $1.5 trillion more for the same level of healthcare or worse than countries like Japan, like UK, like France, Germany provide. So we need a better solution. It's just that simple, and it won't be by band-aids or minor changes. The system needs to change because of the design it has reached, which is a non-functional design.
I want to bring it back to your book because as you were talking, it was just striking me that disease knows no politics. And that's the message of your book and your story and your art and your incredible innovation that you've just shared with us. Just a few stories of all the different innovations you've tried to bring forward. So my question related to that is, have you been able to find any group or region or country that has been able to get beyond the politics?
No, no. I mean, my title is more a manifesto, a wish, than a reality. It's so, you know, when things get very, very large in any country, it becomes political, okay? I mean, we cannot separate politics from healthcare, for example, or even science. But there are ways of integrating the two in a positive way, right? I mean, to me, if it's like healthcare is like having a car that has two steering wheels, one going left and one going right, right? And then it never meets in the middle. That's what I'm trying to convey, that there is a better way. And in fact, America can do it. Why? Because in my book, I also talk about the American dream. And to me, I live the American dream. And I also tell people there's no other country that can do that. I mean, look at the number of immigrants like me who have been successful. Half of our Nobel Prizes are foreign born, and 25% of our economy came from that. Look at the leaders of the major tech companies today, biotech companies in Silicon Valley, in Boston. So America is able to enrich its talent to a level that no one else knows how to do. My story would not have existed anywhere else but here, and I thank the country for that. And I think we do, as people, have the talent and the ability, if you will, to create 1 + 1 = 3 and 4, because we know that innovation and creativity is at the core of who we are. And I think no matter the ups and downs, I trust the American people. We'll make all the mistakes in the world, but we'll find a solution.
Thank you so much. That was fantastic. I love that. I was going to ask you a question about hope, but then you summed that up for us. So it sounds like we should have hope, and I'm happy to hear that.
Oh, definitely. Never give up on the American people. That's my experience of 50 years. I've always been greatly surprised by greatness, as much as surprised by other things, but I don't want to talk about those things. They will go away.
Thank you so much. This was really a fantastic conversation.
Thank you. I enjoyed it too.
Totally brilliant. Thank you so much, Dr. Zerhouni.
Thank you for having me.
And thank you all for watching. We'll talk to you soon. Bye-bye.